Hi, everyone. Welcome. My name is Shabir Musa. I'm going to just take you through some very quick processes before we start with our panel. And I hand over to the hi, everyone, to the moderator. If you can just give me 2 secs. We basically are sharing with you. Let me stop that share for a moment. Let me just go through the issues very quickly. So welcome. I'm going to just show you this quick video by Dr. Tedros. If you can't hear it, please let us know in the chat.
To safe maternal and newborn care. Childbirth should be a time of celebration for families and communities. But for too many, it is a time of sorrow and grief. Every day, nearly 5,400 babies are stillborn, and more than 800 women and 6,700 newborns die mainly around the time of childbirth. These deaths are mostly avoidable with safe and maternal care and newborn care by skilled health professionals supported by a strong health system. The Global Patient Safety Action Plan 2021 to 2020 provides strategic direction to eliminate avoidable harm in healthcare. WHO has also established a global network of partners for improving quality of care for maternal, newborn, and child health. To mark World Patient Safety Day every year, monuments around the world are lit up in orange as a show of global solidarity. This year, let's paint the world orange for safe maternal and newborn care. We call on all countries, health workers, communities, and partners to act now for safe and respectful childbirth.
Grammarly.
So let's go back to our presentation. Essentially, welcome to all of you. I'm going to go through some very brief elements. Firstly, I hope you all know how to work with Zoom. So you know how to unmute and mute yourself. Let me show my video while I'm talking. You can use the chat function, and then there are reactions that you can provide. You can also raise your hand by clicking on that and finding it. Please don't forget that we have an English-French translation. Please use it if you need. So there's some basics on Zoom. We also want to get you to use Mentimeter. We should have warned you to download your Mentimeter, but I'm sure that most of you have got it. If you have not got it, go to either Google apps, Google Android, the app download on either Google or Apple, and just look for Menti, and you'll find it. You can try and engage later. We do want you to use it for the rest of the session, especially feedback in the latter half of the session. So let me just go through it with you. So just download it. You should see that it allows you to put a code at the top into the screen, and that's all it requires. Once you do that, you'll come across the set of questions, like, for example, what we have. As you're going along, if you're struggling with the code, don't forget it's actually always at the top. So like the code is now in big, if somebody can just copy paste that into the chat for others so that they can remember it. It's 597-299-82. So I'm just putting it into the chat, and you can see that now, 5972-9982. So in terms of the process, we'd like to get you engaged. So here's the first question. If you can put that out, which country you're from, so that we can get a sense of that. If you can start digging into it. If you can use Menti, it'll be really good. If you're struggling with Menti, let's see, we can catch up on that later. Let's launch a poll. You can actually put it into the poll right in front of you as well, but we would like you all to try and download Menti and use it a little later. But if you can, will you please just click on where you are from? And the next question, what's your PHC team background? If you can just put it out there so that we have a good sense of the people and in the meeting today. We have 29 people from all across Africa, seemingly. So really, we'd like more than just the 6 of you to put your poll in there. If you can, while we are proceeding with the rest of the workshop, to get Menti, download it and add that in as well. We'll try and show it using Menti, these same questions. So great to have all of you here. Wonderful. Somebody's from Spain. Great stuff. So I think we are at 11. If we can get at least up to 15, I think we will then share the poll on the poll. So if a few people can add to the poll. All right. Okay, we'll stop there. So here's the results of the poll. You can see that we have people from Southern Africa, East Africa, and West Africa, some from outside Africa, nurses, doctors, and others. And I'm sure we're going to get to know you a little better. So wonderful. So here you can see the results for yourself. So that's basically the people in the room. So we would love you to use Menti as the 2 people have begun to use it. So we can see also what is your profession. And it'll pop up here and be easy for us to share our own thoughts. We're going to ask you questions related to the discussion that we're having now. So we really would like you to engage. If you're at all struggling, the link to Menti, just simply, I think, is it Kefilat, is asking, can you put the link in the Mentimeter in the chat? The link, if you're looking for Menti, just look in your app. Sort of in either Mac app, Apple apps or Google apps, and find that there. I think here's somebody giving it to you. But what you do is you download that app. It's just literally quickly, but then you have to use the code. The code is always above, so you can see, go to menti.com and use the code. So just use that. Right. I'm sorry, this tends to take a little bit of time, and if you have the 2 people that are here, you don't need to download. Thanks, Maria. So if you can just put up some of your emotions, just to give you a feel of how you can use it. So I'm going to move forward because we tend to find it challenging time-wise to spend too much time on this. If you have any questions, Q&A, you can either use the chat, but you can also use this Q&A in your Menti as well. So let me just stop there. I think we've taken quite a bit of time. I think we've talked about Zoom overall. You can basically use your chat and your question and answer and start and stop your video. So the sessions basically is a panel that we will have, and we're really pleased to have them, and we will introduce them shortly. We'll have group discussions where we'll all break up, and then we'll get some feedback from your group discussions. At this point, let me stop and say I will hand over to Dr. Joy Mugambi. Dr. Joy Mugambi is the Secretary of the Wonka Africa region, World Organization of Family Doctors. I'll hand over to her. She'll moderate the rest of the session. I'll be able to assist on part of the panel as well. Thank you. Over to you, Joy.
Thank you very much, Prof. Shabir. I am working from my part today, but I hope that we can run this as efficient as possible. We welcome Marie and the team that will take us through this session, and we hope that you will have a very good session as we go ahead. So without further ado, I would like to welcome Maria Pilar, who is our chair for the Wonka Working Party on Safety. And she will also be able to welcome the next the speakers that are with us today, and then we'll move on. Welcome, Maria.
Hello and good afternoon to everyone who is joining us in this fantastic workshop. We hope we have the pleasure to share opinions and suggestions to improve patient safety around primary care in Africa. Thank you.
Thank you very much. Perhaps I can ask for a few words of welcome by the AfroPHC president, vice president, Françoise in Wabufo. Françoise, would you like to make some few comments, welcoming comments? And then we'll hand over to the panel.
Hi, everyone. I'm Françoise Nwabufo from Cameroon, the vice president of AfroPHC. We are really delighted to have you all here this afternoon on this workshop on such an important topic, quality and patient safety in Africa. As we are all in the month of celebration of the World Patient Safety Day, and it's quite interesting to talk again about safety and patient safety, especially concerning the primary health care. So we are glad to welcome you all here, our wonderful speakers and participants. We hope that you will find this session very interesting and pull out of this session interesting practices that will help us to forge ahead with better safety of our patients. Thank you all.
Well, thank you very much. Wonderful to have those few words. Perhaps I think that just to help Joy, do you want to run through the panelists quickly? And I think, Maria, you know, we had the expectation of Nikhil. I'm not sure that he's here. Sorry, Maria, you're muted.
And I want to introduce Dr. Nikhil Gupta from the World Health Organization Patient Safety Flagship. Please, Nikhil.
Thank you so much, Maria and Dr. Shabir and everybody for inviting me. And yeah, I look forward for a very rich and thoughtful discussion. Thank you very much. Bye.
Thank you, Nikhil. Perhaps we can, the program, we can proceed with you, Nikhil, presenting on the Patient Safety Day and the Global Patient Safety Action Plan. And then Maria can go through, I think, some global perspectives, and I can just share with my colleagues some perspectives from Africa. Does that seem right? All right. If you need to share, just let me know if there's any difficulty.
Dr. Shabir, so I have a, do you want me to just give a talk or you want me to present some slides? I have
Anything
some slides,
but
I can't share the screen because I am registered. So it says host disable the participant screen sharing. So you have to enable me for sharing.
Would you mind just picking up your hand? What is the name on? I can't seem to pick up the name. Nikhil.
Nikhil,
Sure.
could you see me on the screen?
Yeah, I'm just looking to see why I don't see your. Ah, there you are. All right, there we are. Okay, so I've made you co-host, and I think Maria Pilar as well, and then we can proceed from there. Go ahead.
So could you see my screen, the presentation?
Yes, wonderful. Thank you.
Great. So let me make it on the presentation mode. Yeah. I hope I've been allocated 20 minutes for this presentation. If there is any revision, please let me know.
No problem. That's more than fine. Thank you.
So hello, everyone in Africa and from wherever you are joining across the globe. I am Nikhil Gupta. I am a technical officer in WHO Department of Integrated Health Services, specifically working in the patient safety. We have a small team there. It's called Patient Safety Flagship. And so I work there for last 3 years. Earlier, I've been involved in frontline patient safety and quality improvement work. in low and middle income countries, including India and a lot of other countries. Also involved, I will be talking about that. I was having a privilege to organize a big consultation in Cape Town in 2019 about Africa Patient Safety Initiative. Maybe some of you might have joined that or might be knowing about that initiative. So I will be talking about a bit. So let me now come to the subject. We are all here, so for discussion about patient safety. So some of the aspects you might be already knowing. What WHO and globally, we have some flagship initiatives. First of all, the World Patient Safety Day. We are commemorating this year with focus with the theme of maternal and newborn safe maternal and newborn care. That's the third World Patient Safety Day. And we just concluded a global summit on 17th. And hopefully there must have been a lot of local, at the national level, at the regional level, a lot of events must have been organized. And we are also collecting information about that. So we always feel very motivated and very, very enthusiastic when we see that it is just established 3 years back, but we can see a very, very great and participatory kind of reaction from all across the globe. What also specifically I wish to talk here is about the Global Patient Safety Action Plan. This has been just released in August this year, after it has been approved by the World Health Assembly, 74th World Health Assembly in the May. And I will be just giving you some bit of overview. What is this action plan about and what is specifically for the primary care also. I will be focusing on that. And I will welcome later on in the discussion if you have some queries or if you have some suggestions, because just a very new document, very new framework, and we have 10 years to implement it. And when we are talking about implementation, it's not about only policies and having tools and documents, about having the real change at the point of care. And as we know that primary care is a very, very important component of that. Even when we're talking about patient safety, around 40% of all medical errors are happening at the primary care level. So if we wish to improve the patient safety, of course, the primary care is one of the most important area where we have to focus upon. Also very important because classically, patient safety is more looked into hospital-acquired infections and surgical, kind of more hospital-based discourse. We have not been successful in kind of having that much of discussion and technical tools in the primary care. So there are certain WHO tools, and otherwise also Wonka is working with us in a lot of aspects to improve patient safety in primary care, but it's still lot to be done. There's a lot of opportunity there to work, and the Global Patient Safety Action Plan can become a vehicle, a kind of a framework, a template to implement patient safety in primary care. Let me. So as I said earlier, you might be aware that in 2019, the World Health Assembly, the 72nd session, the Assembly passed a resolution on global action on patient safety. And with that, the World Patient Safety Day, what we are celebrating now, was established on 17th of September, as well as there was a mandate specifically for a global patient safety action plan. So the mandate was very specific and very clear that formulate a global patient safety action plan in consultation with member states and all relevant stakeholders, including private sector, and to be presented in the World Health Assembly after 2 years so it can be taken in the consideration and is made available for the implementation. So this went very well according to the plan. We submitted the draft action plan this year in May to the 74th World Health Assembly, and it was by without any kind of a barrier. It was passed with the support of all member states, and now this is a live document. We released the document in August, and very soon we are also. Right now, it's all available in English, but I know that there will be some questions regarding when it will be available for French or Spanish. So we are translating, and it will very soon, by the end of the year, this action plan will be available in all official UN languages. So just to understand the background and what is the purpose of this action plan. So very much, of course, this provides a strategic direction to all stakeholders. When we're talking about stakeholders, not only about policymakers and at the very higher level leadership, the stakeholders also means the care provided at the very much at the point of care, as well as a very much integral part of the care. The patients and family, because we take them as a co-producers in healthcare. So when we say stakeholders, they are also very important stakeholders. Also, we are requesting the member states, the countries, to develop a national action plan on patient safety, and this global action plan could work as a template for further national action plans. Also, it provides a kind of platform where we can align all existing initiatives on patient safety and allied themes to improve the care at the point of care. As we understand, patient safety is a very much interdisciplinary area. So we can't think about improving safety or reducing the error just focusing on certain things. We have to look into the broader health system, WASH, health worker safety. So a lot of other areas also very much affects the patient safety also. So this is the overview of, I'm not sure how much you can see on the screens, whether the text is visible enough. But this is an overview of the action plan. We have a vision, then we have a mission and the goal to achieve this vision. And then we have 7 strategic objectives. So the vision, as you can see, it's very much overarching and very ambitious, but that we need to have a vision like that. So vision is a word in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. So when we are saying safe, we are also adding respectful care also. So the softer aspect of the care also. It's not only about absence of harm. It's also about a positive approach to the care. So it should be respectful. And I'm not going to read out all the things because we'll be discussing in the later slides. But specifically, if we see the goal, it says achieve maximum possible reduction in avoidable harm due to unsafe healthcare globally. So we are using the term maximum possible reduction because globally we can't put a figure, because every country, every hospital, even I would say every primary health center, they have their own baseline from where they are starting. Some of them may be at the quite advanced stage, some of them might be just starting their journey towards the safer care, towards the patient safety. So we will try to achieve maximum what we can do within the capacity, but we can't put a figure here that what could be done very specifically in the terms of numbers. This is supported by 7 guiding principles. Those are there. And then we have 7 strategic objectives that I will be discussing in the further slides. So as as I earlier discussed, that we have 4 very specific stakeholders. There may be even 10 classification. This is kind of a grouping of all the stakeholders what we have in this action plan. These are either those are grouped as governments. Government means ministries of health, as well as their institutions and organizations. Those help Ministry of Health in implementing the health system at the national and at subnational level. Healthcare facilities and services, people like what we are having in this meeting, those who are providing health services, maybe in a tertiary care hospital, in a primary care, or maybe providing at the community level, maybe an immunization program, or maybe even a preventive health program. So those are all grouped as health care facilities and services. Stakeholders, we are targeting those non-governmental organizations and the institutions. Those are very much critical, including the funding agencies. Those are critical to achieve the goal and the mission of vision and mission of this action plan. And the World Health Organization, of course, because the task has been assigned to WHO to develop and implement this action plan. So these are the 7 strategic objectives in which this action plan has been arranged and designed. So the first strategic objective is regarding the policies for avoiding the harm. And then we have second one on high reliability systems. I will be explaining a bit each of them when I will go further. Let me go even one by one to each of them so I can explain them better. So we have these 7 strategic objectives. And with each of these strategic objectives, we have 5 strategies. So in total, we have 35 kind of broad areas of work, I would say, where we need actions from all 4 stakeholders. So if you go through the document, I can share the link, or somebody can, in the chat, we can share the link of the action plan. So these all 35 items, I would say, are actionable, relevant to all 4 stakeholders, say government, healthcare facilities and services, stakeholders, and World Health Organization. I will just elaborate them a bit. So the first one is regarding the strategic objective is regarding policies to eliminate avoidable harm in healthcare. So it's more about having regulations, about having frameworks, having an action plan, having all those environmental factors that will enable at the point of care a safer delivery of the health services. If we go a bit further in this strategic objective, we have 5 strategies, like countries having a patient safety policy, strategy, and implementation framework, how to get resources for patient safety, because we need some resources to implement patient safety, both at the policy level as well as at the local level. Then third one is regarding having a legal framework, because for patient safety, we need some legislative or regulatory framework, so we can implement a just or safe culture, and those who are reporting can be supported, and they are not facing any kind of a punitive action. Strategy 1.4, we are talking about having some safety standards, as well as about the regulation and accreditation. It may be a licensing, it may be accreditation, it may be a certification. Again, this is all relevant and has to be adopted at the local level. But this is another important area of patient safety. And then, of course, what we are celebrating, the World Patient Safety Day, and you might be aware of global patient safety challenges. The third one right now we are implementing on medication without harm. Earlier, WHO launched with support of all stakeholders, one on clean care, safe care, and another one on the safe surgery. So these were two earlier challenges. Now the third one we are having. I'm just looking at the time. Where is clock? So I'm not crossing the time here.
Yeah.
Could you suggest me how much? Because usually
I think you'll have to manage it a little bit better. But thank you for trying, Nikhil.
Okay.
If you can just, and sorry, Nikhil, will you share these slides with us as well?
I've just mailed you, and
yes, you can do that later.
Yeah, I will share it to you.
And then, so you don't need to worry; they will get the details later. Yeah.
So the second one is strategic objective is regarding high reliability systems, and here we are more focusing on some very important aspects of patient safety. Those are more system aspects, like having a no blame culture and a culture of open communication and transparency. Also about good governance in the healthcare system, developing the capacity of for the leadership. Very important, human factors and ergonomics principles should be implemented in all the processes and the structures, as well as also talking about it is very much relevant in a lot of areas in Africa, the emergency settings and where we have extreme adversity, how to ensure patient safety. The third strategic objective is regarding specifically the clinical processes, and it is very much near to the point of care, specifically this objective, where we have specifically a strategic objective regarding risk-prone clinical procedures like surgery and anesthesia, but also about the medication, infection prevention and control, medical devices, blood, and vaccines. And very important, what we are here, strategy 3.5 about the primary care. And there are very specific actions in this action plan for the primary care. I won't read out all of them because we have document, we can share the link and this presentation, but we have very specific actions for what governments needs to do specifically for primary care and the healthcare facilities also. And some of these are already part of the health system building, like having kind of a good patient record system, and having SOPs and implementing the reporting and learning system at the primary care level. But it just saying it, we have a lot of work to be done, specifically in the primary care. So I will just, we have very specific actions even for WHO to be what has to be done to improve safety in primary care. The next one, very important, the patient and family engagement, because we consider patients as co-producers, not only as a passive. It's not like having a passive recipient of the care. They have to be involved from the very beginning of the care. So we have specific strategies here regarding co-development of policies and with the patients and learning from their experience in improving our care, as well as having patient advocates and champions. Also, when a harm, though it should not occur, if it occurs, how to disclose all this, because this is very much important for having a transparent work culture and involving patients to have a procedure of disclosing any incident to the patients and families. And of course, also information and education to the patient and families regarding patient safety and otherwise also how to access the healthcare. The next strategic objective is regarding health worker education, skills and safety. Last year, we celebrated the World Patient Safety Day with a focus on health worker safety, very much relevant these days with COVID coming and a lot of health workers being affected by that. So this strategic objective talks about and mandates very specific actions on their professional education, their training, and also about their competence and linking patient safety with appraisal system of health workers, and very much important, having a safe work environment for health workers. Strategic objective 6 is regarding information, research, and risk management. Very important part of any patient safety system is having a patient safety incident reporting and learning system. And I would say this is one area where we can focus in primary care right now, because in hospital, there may be even some kind of still maybe in second tertiary care, they may have an incident reporting system, but primary care, this could change a lot of things, because we even don't have idea what kind of harm is occurring in the primary care. We have some kind of studies isolated, but we don't have much information about what is happening. That's one of the OECD report. I think later on I saw slides we were talking about, but primary care is one area where we are still flying blind. So it's need to be, so this is the strategy 6.1 where we're talking about patient safety incident reporting system. Also, there are strategies about having a surveillance system, having a patient safety research programs. Here also we can have a lot of scope of primary care research for patient safety, and also implementing digital technology and tools for improving patient safety. The last one is about strategy, partnership, and solidarity. And we have some certain strategies here regarding how to engage stakeholders and create patient safety networks. I would say, like this one where we are talking here, we have a network of primary care family physicians here, and we are talking about, so what we are talking here, like strategy 7.3, having local, regional, national networks of patient safety and collaboration. So these are, in short, these 7 strategic objectives. And then we have a program, kind of a overarching normative framework, how this will be implemented. I won't go much into detail, but the focus is, it's not only upstream or downstream. We have to go from both sides. So we have to go from the policy side, from the ministries of health, but we at the same time we have to start the implementation from very local, from a primary health center, maybe a single doctor clinic or a hospital also. Then only we can achieve. We can't wait one thing to happen to only proceed. We have to be more pragmatic in this nature. There are certain indicators given in the action plan. I won't read all of them, but there are 10 core indicators that we are requesting all the countries and health system to measure. And WHO will be doing some kind of a monitoring on these indicators. And then there are a set of advanced indicators also. Sometime maybe later on, if we have a technical discussion session, we can discuss about those indicators, because some of them are very specific to primary care also there. What I was telling about that we had a very specific initiative for Africa. It is still on. It's called Africa Patient Safety Initiative, where 4 very important the organizations, those who are working in Africa in this patient safety area: WHO, IHI, and ISCOA, as well as Patient Safety Movement Foundation, and a lot of other stakeholders. They came together and had a brainstorming that how we should go, what should be the approach, and how we can synergize all our efforts and energy resources to improve patient safety in Africa. And this meeting, so yeah, this is, we had representation from 23 countries, mostly from ministries of health, as well as those who are working in the NGOs and non-governmental organizations. And we came up with this declaration there, a recommendation that's called Together for Safe Care. And there we have these 8 mandates that what we should do to improve patient safety in Africa. Most of these are also now aligned. I would say even these were informed, these were factored in when we were developing the action plan, because action plan came. So I would say what is the action plan now globally? There is a significant contribution from what we get input from Africa region at that time. So that was, this is Africa Patient Safety Initiative. So I think this is, thank you so much for giving this opportunity, and I look forward for working further. And if you have any queries or want me to discuss anything, I'm most welcome. Thank you. Oh.
No, thank you, Nikhil. I think that's wonderful. Really appreciate it. Joy, are you able to contribute if you feel? I'm not sure that you're okay. She was struggling with some power issues on her side. But thanks, Nikhil. I think that's really encouraging that, in fact, a lot of the issues from the African consultation, were helpful to you. We'll probably have a discussion later. Let me, if there are any questions, I don't know that anybody has any specific questions, if they've put it in the chat or the Q&A. But let's move to Maria Pilar, and Maria can share sort of from the Wonka Working Party perspective, the kind of work that's being done. And then depending on time, we'll try and just stimulate some thought around sort of what's happening in Africa and some of the challenges in the African setting. Between myself, Dr. Mugambi, and Francoise and Wabufo, we'll just contribute a little bit, and then we'll break up into groups to discuss issues. Thanks, Maria Pilar. Maria, you need to unmute. And good to go. We can see the slides. Great. You need to unmute, Maria.
Here.
Good. Now we can hear you. Great. You can proceed.
Okay, right. Because once I put in full screen, I couldn't open the micro. Sorry.
True.
So do you hear me properly? And you?
Yes, we can see and hear. We can see the slides and hear you well. Great.
Okay.
Thanks.
Good afternoon, everyone. First, I want to thank you to Dr. Sabir Mosa and Dr. Joy Mugambi and Francois as well for the invitation to join this workshop to the African Primary Healthcare Network. I am a family physician. I work in a public health center in Zaragoza, Aragon, which is a region in the northeast of Spain, nearby the Pyrenees Mountains, and I do clinical visit every day. I am the chair of the Working Party on Patient Safety in Primary Care of the Spanish Society for Family and Community Medicine. We have a blog, Safe and Sound blog, in which we publish news regarding patient safety in primary care in Spain and internationally as well. I'm now finishing my second period as a chair of the Working Party, the Wonka Working Party in Quality and Safety in Family Medicine. I've been chairing this group for the last 4 years, and it has been a very important stage in my life. I will stay in the group to help the new chair to continue raising awareness on healthcare quality and patient safety in primary care. The Institute of Medicine of the United States of America, in its report Crossing the Quality Chance, described healthcare quality in 6 dimensions: patient-centered, effective, timely, efficient, equitable, and overall safe. This is the dimension that fully understand the quality dimension, means that is the basic one we have to deliver in every point of care. Regarding patient safety dimension, the World Health Organization has enhanced the need to provide everywhere and in every facility a safe healthcare, which is the prevention of errors and absence of effects to patients associated with the healthcare we provide every day. This statement became a policy commitment developing through national and international strategies, commitment for healthcare organizations to develop concrete programs, And finally, a commitment for us, health professionals in primary care level, to deploy patient safety culture and patient safety good practice in our daily work. World Health Assembly in May 2021 approved and launched Global Patient Safety Action Plan 2021-2030, as Dr. Nikhil Gupta just explained to us. The plan is organized in different objectives and strategies, but is essential to increase patient safety in healthcare organization and particularly in primary care. Coming to the WHO, World Health Organization definition of primary care, as it is defined as socially appropriate, universally accessible, scientifically sound first level of care, provided by a sustained, suitable, trained workforce, which is supported by integrated referral systems and in a way that gives priority to those most in need, maximizing community and individual self-reliance and the participation and involvement collaboration with other sectors, which includes health promotion, illness prevention care, advocacy and community development. But we ask ourselves, does primary care definition make the demands, the dimension of healthcare quality of care stay? Well, we're going through it. Primary care is patient and community centered, so socially acceptable and universally accessible. So we try to cope with the universal health coverage through primary health care. This is really a challenge for us to reach it, to link primary health care and universal health coverage for all. At the same time, it's scientifically founded and sound first level of care. So we care of our patients along days, for example, treating in the best way possible with chronic problems as high blood pressure, diabetes, or acute ones as myocardial infections, or a depression outbreak. Primary care is as well effective in the way is provided by a suitable trained workforce that contribute to the care with a multi-professional perspective: doctors, nurses, pharmacists, physiotherapists, social worker, midwife, administration staff. It's supported in an integrated referral system. We try to provide care timely and appropriate, to provide care when it is needed, to, for example, referring patients to emergency units or to a specialist consultation, or analyzing the need of a nursing home or some home aid or some home visits sometimes. Overall, it's equitable. Primary care gives the opportunity to those more in need. We know that social and community networks will help to include all people in the care we provide. And we, as primary care, are the foundation of a universal health coverage. Finally, we try to involve collaboration with other sectors and with the community, patient and community-centered care, always considering to involve patients and families in their safety. Nevertheless, unsafe and ineffective primary care have directly impact on people's well-being and increase mobility and preventable mortality. It may lead to a more use of hospitalization and specialist resources use, and in some cases leads to disability or even death. So we have to consider the economics of patient safety in primary care as well. We have to remark that primary care has increasing complexity due to more chronic and complex patients and the use of more high-risk medications among them. We know that regarding some errors, the causes and consequences are not linear in the magnitude of their impact. The studies on patient safety traditionally focus on hospitals, where most serious incidents happens. Traditionally, primary care has been perceived as a low technology environment where safety would not be a problem, but it estimated that approximately 85% of patients' incidents in primary care are related with multimorbidity, polypharmacy, the use of high-risk medications, and it makes primary healthcare more complex every day. We need to deal with health risks in primary care. We know there are near miss, which are risky situations that are detected previously to happen an error, a mistake on the vaccine we are going to put, and then just before giving it, we realize and we change the vaccine. That is a near miss. Nevertheless, 1 to 2% of general practice consultation may result in adverse event, that patient safety incidents with harm. Some of them are preventable, so it's there where we have to work. However, we don't know exactly which patient should be harmed in our waiting room. We are aware, we have to be aware, we can have at least 2 adverse events per week in our consultation regarding statistics. We have to raise awareness and to try to reduce the probability to occur. The patient safety incidents more common in primary care are related with administrative and communication incidents, patient identity, lack of communication among professionals and patients, sometimes diagnostic incidents like early closure of diagnostic processes, misattributing presenting symptoms to readily available diagnosis, or prescribing and medication management incidents as localized and the like medications, not taking into account allergies, lack of supervision of medication, and so on. We need to strengthen our ability to do a good risk management in primary care, starting with the quality cycle and move to develop into a risk management cycle. We have a high risk situation nowadays because the coronavirus in the society and in primary care facilities. On one hand, there was at the beginning a big gap of scientific evidence, which has been reduced partially a long time. On the other hand, the pandemic changed the way we care. We need to analyze this context from the perspective of patient safety in our facilities. This patient safety perspective is a systemic perspective to analyze, always systemic. We do not look for a guilty party or a culprit. Systemic ways means to analyze which are the barriers this system provided that didn't work properly and try to restore those barriers to reduce the possibility to harm to patients. The strategy is to improve quality and safety in primary healthcare. We can show a proposal in this Ishikawa diagram or fishbone diagram. We need to focus on professional training and teamwork and communication, safe use of medications, to build a learning healthcare center, to guarantee proper structures and proper resources to deliver a safe care, and finally, to involve patients and the community in a safe journey in the health system. Regarding education and training, I have to highlight the importance to introduce the curriculum guide in university degrees of patient safety and in the training of the new family and nurse primary care professionals, whose patient safety curriculum is available in the webpage of the World Health Organization and is oriented to multi-professional primary care health professionals. Another area for improvement is to promote teamwork communication and emotional support to the team. So to promote non-technical skills as cognitive and social skills exhibited by individuals in teams, to reduce error and improve human performance in complex systems. We have not to forget that we are learning organizations to enhance and promoting reporting mechanisms to medical errors in primary care, through organizational or regional reporting and learning systems. Whereas, if there is no availability to a regional reporting system, we can work it out in our health centers, facilitating clinical meetings to talk about patients where things didn't go as was planned for us. And sometimes we can avoid harm, and if an adverse event happens, it's essential to learn how to provide a proper response to the first victim, which are patients and families, to the second victim, healthcare professionals, and particularly the third victims that are health institutions. Our health center lose the confidence and trust of the society, so we have to work out to recover them. If we do not get any support to health professionals that have been involved in an adverse event, the professional becomes emotionally isolated, limits communication with the team, have a negative impact on teamwork, suffering with negative personal and professional impact. Therefore, this professional may make more errors and then go on working in a surviving mode or burnout mode, or will drop off. That is the worst result. Whereas if we can care of them, they will thrive and continue working and being a new patient safety champion for our organizations and for the rest of the healthcare workers. Regarding the different strategies to support second victims, I only want to mention the For You program from the University of Missouri, conducted by Susan Scott, which is based in 3 tiers. The first tier is the essential one in local support. So the first tier is primary care team support to those who has been involved in an adverse event. We have to take care of our colleagues who have been involved in those adverse events and help them to thrive and overcome the situation and reduce the possibility to make another error again. Another strategy to improve is the use of medication, which will reduce patient safety incident in a very important way in primary care. The third World Health Organization World Challenge, Medication Without Harm, provide us different tools and resources to make a safe use of medications. Some tools as patient safety solution in the use of medications, but particularly useful in primary care are the 5 moments for medication safety. Starting a conversation with the patient on how to stop medication, reviewing it, adherence, and when to stop it as well. The World Health Organization provides us with an app for the mobile phone for medication safety use. Finally, there are 3 key actions areas, 3 technical reports regarding the transition of care, the high-risk use of medications, and the fact of polypharmacy in chronic complex patients. These 3 technical reports are really important in deploying a safe use of medication in primary care. We have been talking previously that it was essential to involve the patient and the community. So there are 4 areas in which we have to work. Sorry. Yes, to promote patient safety culture in nursing homes, to increase health literacy among patients, to talk and understand their role in their own safety, to start sharing, making shared decisions with the patients, and to promote social media for safety awareness for patient safety in health centers, to develop blogs, Twitters, Facebook, scientifically founded, starting from the health centers or primary care facilities. We have not to forget that we can provide equally and safety care without any structure or resources. So we need a well-founded structure, to have the ability of diagnostic technologies and PPI for healthcare professionals, to improve our medical electronic records and the connection with the medical electronic records of the hospitals and with the health system as a whole. Developing information technologies to connect with, for example, pharmacists, patients, even public health in pandemic times, and to increase telemedicine options as a way to maintain patient contact, a patient who can't come to the health center or when there is a pandemic and they are not able to visit due to a lockdown, as it has happened in the last months. I think we need to continue improving, as Dr. Nikhil Gupta explained to us, the quality indicators for the Global Patient Safety Action Plan. We need to develop some indicators for quality and safety in primary care settings to continue improving when it comes to develop standards of quality. For example, adapting proposals as from the International Society Office 9001 or the Joint Commission Patient Safety Indicators. But nevertheless, many organizations are developing their own quality and safety indicators. The key is to use a short kit of indicators and start measuring to improve. I would like to sum up in my presentation which are the key issues to improve the barriers. We said at the beginning that some barriers fail and then the error happen and the harm to patients happen. So we have to improve those barriers and make easy for primary healthcare professionals to implement safe practices, safe activities, so we can continue reporting and learning errors, guaranteeing the transition of care with safety, repair the broken barriers, and will lead us to a better care. This image of the cheese slides comes from the James Reason developing of the error, and I have adapted to the primary care level. I would like to suggest you some references to have a look. The 9 World Health Organization technical reports on patient safety in primary care, which focus on very important topics or issues in primary care: electronic tools, multimorbidity, education and training, patient engagement, human factors, transition of cares from hospital to primary care, from primary care to emergency units, to nursing homes, to homes, medication error, diagnostic errors, and administrative errors as well. They are available in the World Health Organization webpage, which is noted in the foot of the slide. Finally, I think there are 2 essential open access books nowadays you can download from internet freely. Is Safer Healthcare from Charles Vincent and Renee Malberti, which give us a whole panorama of the safety of the healthcare organizations. And recently, in February 2021, the textbook of patient safety and clinical risk management, edited by Liam Donson, Walter Ricciardi, Susan Sheridan, Ricardo Tartaglia as editors. And it's really very interesting textbook analyzing patient safety in every particular service unit in the healthcare organizations. They gave some keys, particularly for healthcare professionals in training. And I think we have to increase this training on patient safety in future professionals in primary care. Finally, thank you very much for your invitation, for all the attendees to listen to me. And I think we'll have the opportunity to talk to you later on. And now I give the floor to Dr. Sabir Musa. Thank you, Sabir.
No, thank you very much, Maria. Those wonderful resources and insights that you shared from a global perspective, and I think that thanks to the WHO unit, I think they're doing great stuff, and it seems clear that this kind of information is of real value to family doctors across the world. What I'll do is I'll share some few insights from an African point of view. And we'll take the discussion, and I'm going to try and keep it short. So it's going to be somewhat provocative, but at the same time, I'd like it to be constructive. So let me just quickly get to where I can share. Yeah. So these are just some reflections from Africa. And essentially, we have a situation where, sorry, my screen has disappeared, but nonetheless, let me see if I can find a way to share it where I don't lose my screen. All right. So, the key thing in terms of African perspectives, I think, is to appreciate perhaps some of the history. In Africa, I think we have a lot of human resource shortages, and as a result, we have a lot of very verticalized programs with a considerable amount of task sharing, task shifting, but without the sort of supportive supervision that's required. And many a time, clinicians, nurses, clinical officers, and even now community health workers are being landed up with tasks where they are struggling. And there isn't the kind of support systems. And I think this is true of even family physicians. So the entire problem in primary care is that, no, it's easy, it's cheap. Anybody can do it. So let's just get, it done on the cheap. And I think that's a big problem among governments in Africa, where there is not enough investment into human resources in primary care. And I think it's also a challenge for the world that they seem to not think that's a big enough problem in terms of social solidarity globally. So family physicians have emerged as a clinician, a specialist. And I think why I'm raising that is because the role of clinical governance is in fact quite a key one. And the idea is not for us as a doctor, family physician, to simply provide care to patients ourselves, but in Africa to be able to see how do we build a team as a consultant and trainer, etc., and even reach out into the community. But one of those things within that mix is that of clinical governance. Now, in terms of clinical governance, when I hear the language of patient safety and clinical governance, it tends to emerge from sort of the NHS experience where mishaps occurred with patient safety by negligent providers. And that's the origins of it. It's where the idea that, hang on, this process of having managers do what they do and clinicians out of the loop of management, is not okay. We need to both improve the, accountability of the clinicians, but also improve the other side of it, improve accountability by the clinicians, being that somehow we need clinical leadership sort of in the middle of our organization. Now, that concept in Africa is a relatively new one. And across Africa, that's yet to bite home. And many a time, when I hear the patient safety emphasis, I battle with the idea that, man, when we look at it, there is a lot more that the system creates as problems with patient quality and safety than the providers. And in fact, we are almost victims of the system, where there is little credence given to us as either professionals or as an important part of delivery. And it is just very unfortunate, especially in primary care. So if you look at that kind of set of issues, and I think it's oft repeated, and I want to say that I see some difference in emphasis within the global patient safety action plan, that it does include some of the elements. I tried to get a slide that was shared by Joseph Anna, who's also a board member of the AfroPHC, and I couldn't get that slide. But he basically said, there are these elements, but what really matters in Africa is the system, human resources, facilities, drugs, the availability of drugs, not just the fact that it might be managed badly. And these are sort of very big system problems that we struggle with. Joy, if you don't mind helping me with the admitting of people. So essentially that is the problem in terms of our discourse in Africa. But nonetheless, I'll share with you some brief ideas within the South African setting, which is probably reasonably advanced, in African settings. I think Nigeria and Kenya might be doing similar things. But I'm sharing this as an intervention that occurred as part of the South African government's PHC re-engineering plan, together with the UHC attempt in our country of a national health insurance system. And these were sort of their three key domains that they shared with what they call district clinical specialist teams, which included family physicians across the country, but just one per district of sometimes anywhere from 500,000 to 5 million. And in that setting, they said, well, you need to make sure that these three things happen, that there's some sort of clinical effectiveness, that there's guidelines being adhered to, and we do audits and look for evidence in practice, and that we look at risk issues, adverse events specifically, particularly patient safety, and then patient experience, which is probably the least, used or attended to element, where patients complain and somehow there's some involvement of patients. And the district clinical specialist teams have been doing this mostly around maternal and child health. Even the family physicians that have been appointed are pulled in that direction rather than general, care within the primary health care setting. And that's just a South African experience. And I think that's probably true for other settings. And we'll hear from Joy and Mwabufo about their experiences about, quality attempts within these settings. Many a times the sort of traditional quality assurance directorates within the public service have been driven by infection control as being sort of the primary quality assurance issues. Sometimes, drug availability, and in recent times, sort of facility readiness, which is looking at whether they are achieving basic standards, for example, in emergency equipment or a facility, privacy, et cetera. And most times in the South African setting, which is a very well-endowed setting, the public service has failed dismally at these national sort of standards, which is shocker. And we've, been trying to look at that process. And I think just to mention these very briefly, the effectiveness being, are we looking at it, if we're going to look at the guidelines, is the right care, right patient, right clinician, right time, right way? I think that's the kind of things that we look at. And then the risks being to patients, provider, and organization. And then there's patient experience, which is about educating them, but also ensuring that the experience is good. So these are the sort of biggish elements. And in our experience, and I'm going to be very wary of time, so we must finish by before 12:30 so we can break up into groups. So I'll try and finish in at least 3 to 4 minutes. So in the setting of, and I'm going to share it very briefly, in the setting of Shawelo community practice where I work, which is kind of at a bit of arm's length because we say it's more of a research project, where we've set up a very strong community-oriented primary care, what we call community practice, where the community is very involved. We have community health workers, and in which we have a bit more control because of the little extra funds we have on records and filing and systems and how we arrange ourselves as a team. But we work as a team of clinical associate, nurse, community health worker, and doctors, usually young doctors, and we are kind of on the outside. And we've been able to say, how do we how do we look at clinical effectiveness, looking at guidelines, implementing them with a record-keeping system that's in paper, with education training regularly as part of it. We've even done clinical audits to try and establish that and to refine that addressing of the clinical audit. We've had a very strong process openness that we've tried to create with the team, everybody involved in that process. We've been able to arrange the human resource, the information management has been there in terms of our record keeping system, and we've been able to see how we can address risk management, where we can say we're not only dealing with primordial to tertiary prevention, but quaternary prevention. Are we thinking through what are we doing as harm? And in some ways, it's a big mix, works very well, and we showed some remarkable results, but a controlled environment relatively. I've done exactly the same thing as a family physician, but only, and we've been in family physicians in Joburg from 2006. And it was only in 2018 when we were struggling to be sort of taken seriously. And suddenly in 2018, senior politicians said, no, the family physicians need to be centering this process. And then I was tasked with leading clinical governance within a population of 1.5 million people, Soweto, which is the biggest township in South Africa. And in that space, we led that process again, very openly, trying to bring all the stakeholders together and saying, how do we focus on it? And we had to rely on information systems that came through the public service, because they were finding that the indicators there, which they collected, were sort of, some of them were not doing very well. And they thought these were poorly performing, can we address them? And when we set about that process, we found that there wasn't even enough understanding of the indicator itself amongst some of the facility managers. So they didn't even know that, for example, that some basic indicators were what they meant. And as a result, we had to educate them. Then we looked at processes like that. But a huge measure of the problems we encountered was the simple fact that the managers couldn't manage. So even getting that meeting once a month was a challenge to get everybody there. And when we got to everybody together, we found there's huge challenges with the people's accountabilities and the way in which they function, because we had two spheres of government. We had managers who were not aligned between those two spheres of government. We had problems where the managers were saying, well, we can't do that because it's being managed at a high level. And these were things like, well, where is the condoms being stored? Well, the policy says it has to be in a depot, but that depot doesn't give us information. So we don't know, how we can measure the sort of use of distribution of condoms in our facility per facility. So how can we be held accountable? Or, for example, there was a pap smear problem. So the question became, well, why aren't we having enough pap smears done? No, it was, we don't have the equipment. Who's going to be able to buy it? Well, there's a problem up at the district because they can't buy us that. And then as we are circulating, then they're disappearing as we send them to be cleaned, at a higher level. So these became all the kind of things. And we did all sorts of things like educating, going out, visiting, trying to understand, giving people the ability to think through a quality improvement plan. But at the bottom of it, it became something where, with COVID, it just fell apart. And we couldn't get the managers to meet virtually. They simply refused. They said, no, we're not going to use personal data for public service work, for any work like that. And they fell. And I think this just speaks to the conundrum in Africa of that as clinicians, as people who are professionals on the front line, we struggle a lot with the health systems. Now, that doesn't mean we need to throw our hands up in the air and say, well, that's a problem of the manager. And I think that what Nikhil shared is really very valuable, that we should be looking at this global service patient safety action plan and actually looking at whether there are policies and agitating for the policies, looking at the fact that, what is the system itself? Yes, we might be responsible for safety of clinical processes and we might be able to engage with patient safety. And I assume that we're going to look at it, but I think that the fact that we can find ways through education, research, and partnerships to be able to look at how we can unpack, and I think particularly the research, to unpack what extent of the problem lies where we are within control and what extent of the problem that's avoidable lies beyond. And I think that doesn't mean we can't implement some of these proposals that have been put forward to us. But I think that we need to be more broadly thinking about how we proceed with the idea of quality and patient safety in Africa. And I think that the patient safety, Global Patient Safety Action Plan provides us some template. But I think that for strategic actors globally, we need to find ways, and I think Nikhil pointed out quite importantly that there is very little from primary care. And I think we have that opportunity to take that forward. And I hope, Nikhil, we can explore that going forward. So I'm going to stop there. And perhaps, Joy, you have some comments to add, and Francoise, to what I've said, and maybe you might have an alternate view. Feel free to do that. Maybe Joy, if you can, and then Francoise, your perspectives on challenges, on the question of quality and safety in primary care in Africa.
Thank you very much, Prof. Shabir and the team, and also Maria and Nikhil for that great presentation. When you look at the Africa perspective, Prof. Shabir has shared really where our aspects are, which is not just a South African issue. It's also where I am in the East Africa region. We mainly focus on infection safety, and quality for us is all about quality supplies, quality not centered around the patient's safety, but rather around quality of supplies that are arriving within the facility. When it comes to patients, I think the biggest challenge which we face is the current social media space, where disputes and complaints of medical errors and mistakes that happen in hospitals appear fast within social media pages. And this really puts most healthcare workers into great fear, and you find reporting becomes a big issue because most don't want to report any medical errors or events that could have happened with maybe even a colleague, because they don't know what will happen next in terms of the social media forums and other greater forums where disputes are not sorted out fast at the managerial level. And this leads actually to very depressed states because yes, health workers are few, they are also overwhelmed. And I like what Maria said. One aspect as you sort out patient safety and quality is for health workers to come together and support those who have had issues in terms of quality and safety. But you'll find most of us as colleagues, which are state the other person who has gone through a medical error, and we neglect them. And this really leads to more depression and poor outcomes at the end of the day. I look at our region as a country, Kenya. I remember a survey of 2016, which looked at public and private sector. It was so grim because on less than 5% of facilities in public and private sector could meet the international standards of patient safety. And that tells you this may not only be a picture of just one country within Africa, but it's a picture that's demonstrable in most of the countries within Africa. And this forum that we are having today is a forum which I hope can bring out strategies that can help us as primary healthcare providers to provide the best quality care. So I hand back to you, Prof. Shabir, and I hope the discussions and the deliberations that go on will bring us closer to more quality provision and patient safety, especially in primary healthcare, because when you look at most of these quality care measures, they are more within the surgical departments. That means secondary care rather than within the primary healthcare facilities. Thank you. Back to you, Prof.
No, thank you very much, Joy. Sorry, I was rushing because I want to give you enough time to speak, and I'm wary of time. But thanks for being understanding. I think, Francoise, any comments from yourself, just briefly, and then we can break up into groups.
Thanks, Prof. Shabir.
We can have some comments also from Nikhil. Yes, thank you, Francois. Proceed.
Thank you, Nikki. Thank you, Maria, for the wonderful presentation. And our workshop today is on quality and patient safety in African PHC. I'm glad because there are many Cameroonians here in this forum today listening, and one of them had to say, this is not our context. We don't have family doctors in our country. We don't have that. And Prof, you know, I've been crying that there should be capacity building in our country on PHC. We really, if we don't have those family doctors, we don't have family nurses. In fact, our PHC is still suffering quite a lot. So if there is one country we will start with in Africa to capacitate the health workforce, let's do it in Cameroon, Prof. And so if I want to go to some of the presentation, Dr. Maria spoke on about the impact of low quality care in PHC. There are quite a lot. It is the integrated, it is not integrated. Sometimes, in fact, if we get detailing into what is happening in our PHC system here in Cameroon, you spoke a lot in Africa, so I want to take Cameroon specifically because that has been my cry in our midst. So we really have some challenges, some real challenges that I would just pray that this forum will bring something, make a move, because we are many, I can see many of our colleagues here on the forum, and we really want a change in our context. So we still have quite some challenges on the field as concerned the AfroPHC, the health workforce. Most of the time you find our nurses in the doctor's consultation room, they are not even enough. And so you find them there doing where they are supposed to be somewhere else. So we need to really change in our practice so that the primary health care system will be strong. It is not completely integrated, it is fragmented. The people in the rural community don't get the same capacity building like those in the urban areas. And that is the first level of care. And from the research, we have more than 42% of the people that live in that rural community. How is their health? With that, our health system will be flooded with a lot of diseases and many things to manage because the first healthcare, the point of entry is not well taken care of. Thank you very much. I've stopped here for now. Thank you, sir.
Thank you very much. I'm going to suggest that we break into group because I think Maria and Nikhil will ask you to comment in the time we're getting feedback. I think there'll be opportunity there. But I think we need to get into groups so that people have a chance. I know, Paul, you'd like to say something, but let's use the group discussion to do that. And I'm going to just go through this very quickly. I think we must give you sufficient time. We'll make it at 45 minutes. We'll try and make it that we're back at 3 o'clock for Central Africa time. So if you could just compute it in 45 minutes from now. So let me just quickly run through how it works and so that you're not confused. I'll just show you the breakout room process. Once we break out, you'll see this join breakout room. Please don't click on anything, click on that. Otherwise you might lose that connection. I'll tell you what to do if you're struggling, but just press join and go for it. If you're struggling, once you're in the breakout room, you can also click on that breakout room. Or you can click on it when you are, not yet in the breakout room. So if you're struggling with the breakout room, you can in fact see, sometimes it allows you to join only the one you've been allocated to, but please click on breakout room so that you may be able to join that. And you just click on it, say yes, you want to join and proceed to join. And if you are in the breakout room, you can press leave on the right-hand corner. And you can also press help if you want help as a team. I would like to suggest that each group forms gets a facilitator and a rapporteur, someone who can take notes and share some of the comments, write some of them into the chat, and some of them you can use that to tell us as well. But please put that in chat. So if you could just record on your computer. If you're in group, if someone can just, the facilitator or rapporteur can just please press the record button and record it online on the cloud. Please do that so that we can keep a record of your deliberations. Sorry, I pressed the wrong thing there. Too many things open on my desk. All right, let me just move along. We'll leave, the breakout room will close, and we'll give you about a minute to leave, so you have that time. And if you're still sitting here, please remember, join breakout room. So that's where it is. I'm going to break you out into breakout room now. If you can, we'll try and keep it. If those who are either part of the working party or are panelists, if you can just put P on your name, rename and add P. I'll be able to just make sure in the breakout room I could spread you out a little bit. I'm going to sort of spread out everyone randomly, but I may need to rearrange people according to that. So we'll make it 10. Yeah, okay. So we'll break it into 5 groups, and we'll try and join you so that there is somebody there in each one of the groups. Give me a second, I just see. I think that's reasonable, fine. We'll go in, and if you have someone there, please arrange someone to be the rapporteur and the facilitator. Please proceed. Enjoy. So just click on join breakout room, and you'll be there, and then give it a minute until everybody joins, and you can then arrange yourselves into. Great.